and welcome to today's session. I would very quickly advise those who have joined to please introduce themselves in the chat. I would kindly request those who have logged in using their gadget as their name, like Infinix, Hot, please put your name. And as you introduce yourself in the chat, please let us know which facility you come from, if you come from a health facility, and how many people are logged in onto your device. We begin right away, and it is my pleasure to welcome you to today's session. My name is Ken Agutu, and together with my colleague Sam Agutu, we will facilitate today's proceedings. Today's session is part of the Tele-Education for Clinicians and Leaders in Africa, in short, Project TECLA Africa, which is an initiative between Making More Health together with Ashoka and two social enterprises from Africa, Chronic Drugs Medical Scheme, in short CDMS, who are hosting tonight's session from Kenya, and MDoc from Nigeria. We will be running series on various disease areas, but for now we are on diabetes, and later we will handle hypertension and eventually expand to other areas based on feedback from all of you. Today's topic is classification and diagnosis of diabetes, the second of a 12-part series on diabetes. The first session was held on the 24th of last month. Our didactic speaker tonight is going to be Dr. Eric Njenga Kimani, who I will introduce at the appropriate time. We will also have a case presentation on the topic. The intention of these sessions is to create cross-country peer-to-peer learning by bringing together health workers from across the continent on a platform where they can share knowledge and experience on a wide range of topics. And also share their experience on health conditions through these talks and case presentations from subject matter experts, and having these experts answer questions from participants. Presently, Nigeria and Kenya are acting as the initial hubs, and the initiative will be scaled right across the continent. We have over 100 participating hospitals from across the continent. In Kenya in particular, we have also partnered with the Rural Private Hospitals Association of Kenya, RUFA, among other partners whose representatives have very kindly joined us this evening. We also have a great portfolio of experts from Kenya and other parts of the world. Please take note that Project TECLA Africa leverages the ECO model. We collect details. We collect details of registration, participation, questions and answers, chat comments, and poll responses for our programs. Your individual data will be kept confidential and handled by authorized personnel only. This data may be used for reports, maps, communications, surveys, quality assurance, evaluation, research, and also to inform on new initiatives. This session will be recorded, and we will be sharing a PDF version of the slides after the session. I just wish to outline our online protocol that will enhance your experience this evening. First of all, please rename yourself by putting down your name and the health facility you come from. Please avoid using your gadget model as your name. For instance, having iPhone S9 or Oppo A5 as your name. For security reasons, please use your real name. Introduce yourself on the chat by giving your name and your organization if you're from a health facility, and state how many people are using your gadget. Please have your camera on if your bandwidth allows. This goes far in encouraging the speakers and just helping us all know that we're together. Please remain muted when not speaking. If you're required to speak or given an opportunity to say something, the host will unmute you. You may also use the raise hand feature in Zoom when you want to ask a question, or better still, write it out on the chat, and the chat master will take note. Our technical support team is available to help you on any technological issues, and the contacts of Habil, Achieng, and Robert will be displayed on the screen. Just you need to reach them during this call. This session is projected to take 1.5 hours, and the agenda will be displayed on the screen. At this point, we will get a word from the representatives of the social enterprises, beginning with our host, the CEO of CDMS, Sam Agutu. Sam, you can say a word and thereafter invite representatives of our partners who are present to introduce themselves.
Good evening, everybody, and it's a pleasure to have you with us here this evening. My name is Sam Agutu. I'm the CEO of the Chronic Drugs Medical Scheme, CDMS. We are hosting this series, and this is one of the 2 pillars of our business. We believe in ensuring that the health value chain produces the required results, and one of those is to ensure that health workers and leaders upscale themselves and keep abreast with all developments so as to ensure that there is great patient experience. We also run a group procurement organization that aggregates demand for hospitals so as to lower the price of medication. I would, at this point, like to invite our colleagues from MDoc. I see we have Adora on the call. Welcome, Adora.
Hi, Sam. Hi, everyone. Thank you so much for the opportunity. Can you hear me?
Yes, loud and clear.
Great. Welcome, everyone. Hi, my name is Adora. I am a representative from MDoc. MDoc is a social enterprise, a digital health social enterprise that optimizes the end-to-end self-care support for people with chronic and regular health needs. And we have been doing this through a 4-pronged approach, one of which is contributing to the quality of care that patients receive when they visit their healthcare providers. And that has birthed what we know as TECLA today in partnership with the Making More Health initiative led by Boehringer Ingelheim and Ashoka, and of course with CDMS and other partners. Happy to be here. Excited about today's topic and willing to learn more. Thanks, everyone.
Thank you very much. I would like to also invite Dr. Chris Imbaya from Boehringer Ingelheim, stroke Making More Health. If you can say a word of Jambo. Chris, are you with us?
Hello, yes, Sam, I'm with you. Can you get me now?
Yes, we can hear you.
Okay, great. Thank you. thank you again for continuing this education session and forum from Boehringer Ingelheim and making more health. To be more specific, it is always a pleasure to continue this partnership that is happening through this eco model. And it's great to see it's taking on further levels of engagement with healthcare practitioners, always, of course, with the aim of ultimately seeing that the patients receive better care. So, yeah, we look forward to hearing what's in store for us this evening, and may everybody else feel welcome to this session. Thank you very much.
Thank you very much, Chris. I would like to invite one of our partners, Rural Private Hospital Association. I'm not sure who else is on the call, but I know Pacifica Omambia, I've seen you. If you could just give us a word of jumbo, and if any of your other colleagues are there, we could also acknowledge them. Pacifica, please. Pacifica is an member of the executive committee of the Rural Private Hospital Association. All right. I think maybe we could have.
Yes.
Oh, there you are.
Yes. Hello, everyone. My name is Pacifica Omambia. I'm a member of Rural Private Hospital Organization of Kenya. I welcome everyone to this meeting. Thank you for organizing. God bless you.
Thank you very much, Pacifica. Back to you, Ken.
Uncle Sam, I'm here also. This is Kariuki.
Sorry. I'm sorry. Could I also ask the Vice Chair, Reverend Kariuki? I'm sorry, Dr. Reverend Kariuki, I hadn't seen you. Yeah, please give us a word of jumbo.
Good evening, everyone. My name is Joseph Kariuki. I'm the Vice Chair of RUFA. I want to welcome each and every one of you to this meeting this evening. This is one of the great things that we do as RUFA. Out of our 5 pillars that establish RUFA, education is one. And I'm glad to see some names of some of our very newest members that we met in Kitale, Eldoret, Nakuru, and Naivasha. We completed our Rift tour yesterday, and we encouraged so many of our members to join. And it's good to see some of them in this meeting. I appreciate, and I want to wish everyone well. God bless you and welcome. Thank you so much.
Thank you, Brother Joseph Kariuki. You're most welcome, and thank you for your kind words. I'd like to then, hand over back to the facilitator, back to Ken.
Thank you so much. Thank you, Sam, and for all the guests and partners who have joined us this evening. For those joining in now, like I said, please introduce yourself on the chat. Keep yourself muted unless you've been called upon to speak, in which case the host will unmute you. You can follow us on our social media handles as displayed on the screen. Please take note that you can follow us on Facebook, on Twitter, on LinkedIn, or on Instagram as shown on the screen. And right now, I'd like us to post the pre-poll pre-session quiz. Each of us should please attempt the quiz. At the end of the presentations, the quiz will be repeated to test our learning. So, Habil, can you please post the quiz? Thank you. Let's give ourselves 5 minutes to complete the quiz. Like I said, this is for the purpose of testing our learning. So we'll have a pre and post session quiz.
Would we please ask the person who's logged in as Infinix Hot 11 Play to please give us your name? Infinix Hot 11 Play.
Please, if you have logged in with the name of your gadget, put your name. For security reasons, we want everyone's name, and please use the name with which you registered. Can I see more of us attempting the quiz, please? Let's continue completing the quiz, please. All right, I think we're good to go. Habil, we can end the poll. Thank you very much for all those who've attempted the quiz. We will continue, but for now, it is my singular pleasure to introduce our didactic speaker, who will also be the one presenting the case. Our speaker this evening is Dr. Eric Njenga Kimani. Dr. Njenga is a full-time faculty at and is a senior instructor at the Aga Khan University Hospital, East Africa. He is also the treasurer of the Kenya Diabetes Study Group, the chair of the Kenya Association of Physicians, Nairobi chapter, and the secretary of the task working group in the diabetes, Ministry of Health, the non-communicable diseases department. His presentation will take 30 minutes, but he will also give a case which will take 10 minutes. So we will expect him to be on for 40 minutes. Thank you. Welcome, Dr. Ari.
Yes, evening, everyone.
Good evening, we can hear you.
Yeah, you can hear me loud and clear?
Yes.
I'm just, sorry, yeah. Good, you can see my screen?
Very clearly.
Yes,
Thank
we
you.
can. Yes, very clear.
Okay, good. So we'll start off. So thank you so much for having me on this particular platform. And I'm glad to see all these organizations coming together for the benefit of our patients. Very, very important to provide access to quality drugs to our patients, especially in the rural communities. So I'm glad to see that even companies that I've worked with, like Boehringer Ingelheim, are involved in these particular initiatives. There are several groups I've heard of before, like RUFA. So pleasure to have this particular joint initiative to try and spearhead the improvement of the knowledge base for all our practitioners in the primary healthcare level and for those in other facilities as well. So my name is Dr. Eric Njenga, and as I mentioned, I'm based in the Aga Khan University Hospital, where I'm a full-time faculty at the Department of Medicine, the endocrinology subsection. So our talk for today will be looking at pathophysiology, as well as classification and diagnosis of diabetes. So that will be the outline of our talk, where we're going to outline the pathophysiology of both type 1 and type 2 diabetes, and briefly discuss about other subtypes. I will understand the differences with regard to clinical presentations for both type 1 and type 2 diabetes. We'll then look at a very key area, the WHO ADA diagnostic criteria. Then we want to understand how exactly we can use these particular lab investigations to diagnose our patients and then institute appropriate treatment guidelines. So very, very key, like we've said, we've now moved away from this particular term. Previously, we used to classify diabetes based upon treatment, where we'd have older terms like insulin-dependent and non-insulin-dependent diabetes, which have now been phased off. So very, very key that for those who are still using these particular terms, they're now obsolete in our particular field. So let's now look at how we classify diabetes today. And even this has evolved quite a lot, even beyond what we're going to discuss today, because of the advent of now genomic testing, which has now enabled us to identify specific subtypes based on genes, even if you're looking at other broader classifications in the setting of diabetes. So I just want to give you a snapshot that diabetes is much more than just thinking about type 1, type 2, and GDM. We normally think about the three broad classes, but I just want to briefly take you through how we think about the nomenclature in diabetes classification. We have what is referred to as type 1 diabetes, which is predominantly immune mediated, and we look at the differences and the subtypes of that. Then we have what is called type 2 diabetes, which is a predominant form of diabetes that we see in clinical practice. Actually, it constitutes around 85% of all patients that you'll see in day-to-day practice. Type 1 diabetes accounts for around 5 to 10%. And then we have gestational diabetes, which accounts for roughly the remaining 5%. But remember, we have other specific subtypes which are rarer. We have genetic forms of diabetes, what we refer to as MODY. Don't need to get into the details, but just to show you that even the MODY classification has several other abundant subtypes. And this requires genomic testing for us to make this particular diagnosis, but there is a diagnostic criteria. Then we can have other types of diabetes which are linked specifically to genetic defects with regard to the production of insulin. And that's called type A insulin resistance, and you can have rarer conditions, which will not dwell too much about. Then you can have conditions that specifically affect your exocrine pancreas. These include conditions like cystic fibrosis, C of the pancreas, pancreatitis, for example, are all factors. You can have stones, for example, occurring in the pancreas, and all these can lead to the pancreatic damage, which eventually could lead to the development of what is referred to as secondary diabetes. In the field of endocrinology, there are other conditions which can occur, which can also lead to an increase in insulin resistance. For example, acromegaly, which is normally due to an excess of growth hormone. Growth hormone, as we know, is an counter-regulatory hormone, which will lead to an excess with regard to glucose production. Also things like Cushing's, we know that if you have increased release of your steroids from your adrenal glands, that also will lead to an increase in your blood sugars. We can have tumors affecting the alpha cells of the pancreas called glucagonomas, and also other conditions which affect the adrenal glands like pheochromocytomas. So these are rarer conditions that we see in practice, but it's good to keep them in mind because they can present with hyperglycemia. Because they're trying to distinguish the diagnostic criteria for these particular syndromes. Hyperglycemia is one of the common things to actually look out for. Then you can have direct destruction of the pancreatic beta cells by toxins. And we can have either drugs, or this can also occur through use of steroids. The commonest that we see in clinical practice is the use of steroids, which can be used for various autoimmune conditions. What we commonly came across is the steroid use with COVID-19, where we saw a lot of hyperglycemia in our patients and even some going into DKA. So please remember that some of the drugs that we do use to treat other conditions, for example, lupus, rheumatoid arthritis, can also lead to secondary diabetes by causing an elevation in your blood sugar. Infections, and in fact, what we now know, before we used to think about viral infections like rubella and CMV, but now that the biggest thing that we've seen in the last 2 years, that we've seen a lot of new onset diabetes following COVID-19 infection. And we now clearly know that COVID-19 itself can directly attack the pancreatic beta cells and actually trigger diabetes. So there's now an entity referred to as COVID-19 induced diabetes, which is probably a recognized subtype on its own. And we are still having follow-ups with regard to this and to see whether this actually resolves after COVID-19. But what we are seeing that we are seeing coming across patients in the clinic who developed COVID-19 probably even up to a year ago and are still having requirements for insulin. Some are still on orals and some have had their diabetes resolved. So we're actually doing a study right now to follow the pattern of COVID-19 induced diabetes, whether it resolves completely, or whether some people actually require to maintain treatment on either insulin or oral hypoglycemic drugs. Then we do have other rarer conditions that are linked to genetic conditions we'll not dwell too much about, but that's to give you a snapshot that diabetes classification is much, much broader than just the typical type 1, type 2, and GDM. It's always good to think broadly so as you're able to classify your patients accordingly. Now, I want us to think beyond this classification and now to highlight a case of how actually not knowing how to classify your patients can actually impact on your management. So today's case will be a 37-year-old male. He was lean with a body mass index of 23. This is a patient we came across in Aga Khan last year. He first came to an endocrinology clinic with poor feeding, epigastric discomfort, increased thirst, and polydipsia. And he lost 6 kilos. And this is the time when he presented in July 2021. His sugar at presentation was quite high at 26 millimoles. His plasma ketones were negative. His blood gas was normal, so he was not in DKA. So we commenced him on fluids. We commenced him on insulin, a basal bolus regimen, and he was admitted. And within 2 days, we were able to control his sugars quite effectively. And his HbA1c at baseline at that particular point was 11%. We screened him for any end organ damage and everything was fine. Then subsequently, we did our fasting C-peptide, and we'll discuss that shortly, the relevance of that. And also because the individual is quite lean and wondering why this individual at this particular age would present with such hyperglycemia. And also GAD65 was done, and we'll discuss the essence of that particular antibody, the importance of why we need to do that particular test. Subsequently, he was discharged on insulin. And what we noticed that when he went home, that he was getting several episodes of hypoglycemia. In the subsequent visits, we kept reducing the doses of insulin. He was on 4 injections initially. Subsequently, we had to reduce to 2 injections a day. Eventually left him only on a basal insulin, that was insulin glargine, and we had to withdraw the glargine even within 2 weeks after his discharge. Soon he was only on metformin, 500 milligrams twice a day, and his sugars are very well controlled. And 3 months later, his A1C was down from 11% to 6.4%. 3 months later, he started to have similar symptoms, and he now started having his blood sugars rising rapidly and now going up to 10 to 18. And he was seen in another facility in January 2022, where he was now, the person who saw him there, saw that he was on metformin, his blood sugar is rising up to a level of 18. And so the best thing to do is just to increase the metformin dosage to the maximum of 1 gram twice daily. There were no significant precipitants at that particular time to account for his elevated blood sugar. He had no infections, he's screening for any possible peripheral vascular disease, MI, stroke, and also microvascular complications. Everything was negative. He had an appendectomy 2 years prior. He was not smoking, no alcohol use, and no chronic illness or any thyroid disease or anything else of the sort. HbA1c now increased. Remember, he was very well controlled at 6.4. Now it rises to 10%. And also no evidence of COVID, because the other thing that you want to think about for any particular person coming with unexplained hyperglycemia who are previously well controlled. We are seeing that very, very commonly during the peaks of the COVID pandemic. Subsequently, now he came back to a facility. Now he was quite sick. He was very dehydrated, no pallor jaundice or edema. Blood pressure was on the lowish side, 112/72, pulse of 82 beats per minute. Respiratory rate was slightly high at 18 breaths per minute. And you can see that his BMI dropped now to 21, saturating well 96% on room air, and his blood sugar at the emergency room now was 28.6. Now is the time now he came back to Aga Khan, and his ketones now, as you can see, were unrecordably high. The cutoff for plasma ketone is 0.6 for you to make a diagnosis of diabetic ketoacidosis, and his pH value now had dropped to 7.3, which already is in the range for DKA, and his lactate was high at 2.3. His bicarbonate was slightly on the lower side at 17. So for DKA, if you have a bicarb of less than 18, a pH of less than at least 7.3 and below, and a high plasma ketone of more than 0.6, we conclusively make a diagnosis of diabetic ketoacidosis. So now he's back in full-blown mild diabetic ketoacidosis. And we now want to see what exactly are we dealing with in this particular type. We've talked about type 1 diabetes, type 2 diabetes. We've talked about secondary diabetes linked to endocrinopathies, linked to genetic conditions. And we want to see what are some of the pitfalls that were made in this particular case, and why did he come back in DKA? And that's why, just to highlight, this is not a very common type of diabetes, but not understanding what exactly is a driver or trigger for diabetes and how we manage this patient in subsequent visits can actually impact on a patient. And you can see he's come back in DKA. And in the setting of DKA, if you don't act promptly, if you're not in a critical care setting, then the mortality rate is quite high in the setting of DKA. So I use this particular case just to highlight, we have another subclass of diabetes in between type 1 and type 2 diabetes that we call LADA, and we call it diabetes 1.5. And it's a very gray area where we have individuals who don't fit, they don't quite fit into the spectrum of type 1 diabetes, and they don't quite fit in the spectrum of type 2 diabetes. As you can see, the key thing to actually clinch this diagnosis, you look at the BMI. So if you have someone who's coming in who is much older than what you'd expect for type 1, let's say in his 30s or early 40s, and is coming with very high sugars, then think about this LADA classification. Here are the differences, as you can see. It presents acutely, just like in type 1 diabetes. It is an autoimmune subtype, just like type 1 diabetes. Most times they will require insulin 6 months after you diagnose them. So they can go into a honeymoon period. After the initial treatment, they go on orals, but remember that you must think about insulin use after 6 months. So what that medical officer should have done is to probably refer or start the patient on insulin if he knew what the subtype was. Again, as you can see here, their BMI is rarely above 25. So again, they're normally lean like our type 1, like the type 1 counterparts. And they tend to have antibodies that are being present, which are positive, and we'll see how to detect them. And also they tend to have a risk with regard to family history and other autoimmune conditions. So just to give you a broader perspective of how we classify diabetes, you can see there are several subtypes, and the different subtypes, you need to know what the specific management principles are. In type 1, it's very, very key. If you diagnose type 1 diabetes, the only management algorithm for type 1 diabetes is insulin use. It's still sad that we get people who have type 1 diabetes who come on oral hypoglycemics. Insulin is the only mainstay of therapy in the setting of type 1. In LADA, we start off with insulin, they may go into a honeymoon phase, or you can use oral hypoglycemics, but eventually after 6 months or even up to a year sometimes, they will require insulin therapy. And for type 2 diabetes, normally they're more obese, they're normally older, and most times they tend to present much more slowly, and they have an insidious onset of action with regard to symptoms and hyperglycemia. So just to highlight what LADA is, remember it's adult onset diabetes, normally diagnosed at more than 30 years, less than 50 years most times. We have antibodies that are present, which you can detect, and the common one used is called glutamic acid decarboxylase 65 or GAD65, which you can actually send. Not a common test to send for, it's quite expensive, but if you're able to do it, you can do it. But the key thing to look for, take home message is that you look for any individuals who may come with a BMI, anyone who is lean between the age of 30 to 50, having very high sugars, coming in DKA. Please think about this particular subclass of diabetes. It could be LADA. If you can do the test called GAD65, then well and good. So we'll now narrow back to our commoner types of diabetes, type 1 diabetes. Like we said, that is commonly seen in the children. So predominantly, they're usually below 30 years of age. So it can start right from birth all the way up to 30 years of age. Type 2 diabetes, you commonly say above 40, but nowadays we know that we see type 2 diabetes at a much younger age. So I don't get surprised nowadays when someone comes at 28 years, for example, with type 2 diabetes, because we have a very significant rise of pediatric obesity. Most of us now are not very active in our early to late teens. So obesity becomes a major factor in people in their early 20s. So the sedentary lifestyle, onset of alcohol and smoking very early on is now giving us a transitional shift with regard to the demographics of type 2 diabetes. So we are seeing it at a much younger age profile, even as early as 35 years of age. The symptoms, like we said, develop much more slowly in the setting of type 2 diabetes. Most tend to have normal to obese weight. They tend to have a BMI more than 25, and they can have varying grades of obesity, right from grade 1 to up to grade 3. Insulin secretion is deficient, mostly because of the increased insulin resistance in the setting of type 2 diabetes. In type 1 diabetes, because the pancreatic beta cells are destroyed by these autoantibodies that we've talked about already. And most times you tend to have chronic complications, which could occur due to late diagnosis in the setting of type 2 diabetes. Because they will tend to live for several years asymptomatic, so by the time you diagnose them, most times you may find that they may have some degree of microvascular complications, either retinopathy or nephropathy or neuropathy. But in the setting of type 1 diabetes, most times we don't screen for any microvascular complications, at least for the first 5 years. And same with LADA as well. So with regard to other differences is that ketosis is commonly seen in the setting of type 1 diabetes, can also be seen in the setting of type 2 diabetes, but not as common as what we see in type 1. Remember that 20 to 40% of all people coming in with diabetic ketoacidosis, it comes in as a new diagnosis for either type 1 or type 2 diabetes. So remember that 20 to 40% of all individuals coming with diabetic ketoacidosis as their initial presentation is the first diagnosis point for whether type 1 or type 2 diabetes. Type 2 diabetes is a much stronger genetic link with regard to family history. So for example, if you have one first-degree relative, for example, a parent with type 2 diabetes, your lifetime risk as an individual is 25%. So you have a 1 in 4 chance of getting type 2 diabetes. If both parents have diabetes, your risk increased to 50%, a 1 in 2 chance. If 2 parents and 1 sibling have diabetes, your risk is now 75%. So it's quite high. So remember that if you have strong family history, you want to screen for type 2 diabetes much earlier on. Not a very strong genetic link in the setting of type 1 diabetes. Metabolic syndrome is commonly present in the setting of type 2 diabetes. It's predominantly lifestyle driven, alcohol, smoking, sedentary lifestyle, excessive consumption of highly processed carbohydrates, and they tend to have a higher risk of macrovascular complications, for example, stroke, myocardial infarction, and peripheral vascular disease. We now want to look at the diagnostic criteria, and the key thing to look at is we have various modalities that we use. You can either check a fasting blood glucose, or you can check a 2-hour post-meal sugar, or you can use a HbA1c. So going through this particular checklist, the WHO criteria is for a fasting blood glucose of anything between 6.1 to 6.9, diagnosed what is referred to as impaired fasting glucose or pre-diabetes. Between 5.6 to 6.9 is more accurate for ADA, so it has a lower cutoff. That's a diagnostic cutoff for impaired glucose tolerance by the ADA criteria. For fasting, anything equal to or more than 7 is a diagnostic of diabetes, either by WHO or ADA criteria. If you're using the 75-gram oral glucose tolerance test, any value between 7.8 after 2 hours, between 7.8 to 11 is characteristic of pre-diabetes. And anything equal to or more than 11.1 is characteristic of type 2 diabetes. So remember, a 2-hour post-meal sugar of more than 11.1 or equal to 11.1 is diagnostic for diabetes, or any random sugar more than or equal to more than 11.1. And any fasting blood glucose level after you fasted for 8 hours, which is equal to or more than 7, is diagnostic of type 2 diabetes. And again, if you're using the A1C cutoff, it is equal to or more than 6.5, okay? And for pre-diabetes, it's normally 5.7 up to 6.4% for pre-diabetes using HbA1c. So again, very, very key slides. So please let's take note of those diagnostic cutoffs. They're very, very key to remember. These are to highlight again on pre-diabetes. And again, remember that what we're talking about is for diabetes specifically, just to highlight once again, in a more detailed manner with regard to the newly adopted ADA classification, and other societies also synonymous with this particular guideline. Any sugar equal to more than 11.1, as we've said, or a 2-hour post-meal sugar or audit test or more than equal to or more than 11.1 also is diagnostic, and we've given the values already for fasting and A1C. Good. So let's now look at what exactly does insulin do in our bodies and how exactly we end up getting diabetes. So insulin, as we know, which comes from the pancreatic beta cells, plays a very key role. As you can see, it promotes the uptake of glucose from the bloodstream into the skeletal muscles to enable glycogen synthesis. Also, it enables the uptake of glucose into the fatty tissue. Also, it will reduce the production of free fatty acids by blocking an enzyme referred to as phospholipase. It will also tend to reduce the hepatic glucose output by cutting down or shutting down these particular pathways, either glucogenesis or glycogenolysis, and promoting the conversion of glucose into glycogen. And this overall has an effect of lowering your blood glucose. So insulin plays a very, very key role in controlling blood glucose by using these different mechanisms of how to actually reduce the level of blood glucose by shunting it to various peripheral sites, for example, the muscle, as well as the fat tissue. We now want to discuss about the pathogenesis of the various forms of diabetes, and we'll start with type 1 diabetes. It's an autoimmune condition, and it involves an interplay of various factors, both immunologic as well as genetic, as well as environmental. So initially, you have a genetically predisposed individual, and then he's exposed to a certain environment, and the environmental factors you've seen could also include things like viral infections. We talked about things like mumps, Coxsackie virus, rubella, which could also trigger type 1 diabetes. So initially, when all these factors come together, the genetic factors, the environment, viral infections which could cause direct damage to the pancreatic beta cells, then you have the insulin release now, which initially was normal and starts to decrease over time. So progressively now you have progressive damage of the pancreatic beta cells by these autoantibodies, and eventually you start to have manifestation of your symptoms when 70 to 80% of your beta cell mass has now been destroyed. And the patient now will require lifelong exogenous administration of insulin for them to maintain their blood glucose level. So remember that there's no role for oral hypoglycemic drugs in the setting of type 1 diabetes, because they tend to have complete destruction of their beta cells by the autoantibodies, and therefore they will completely rely on exogenous insulin for them to maintain their blood glucose levels. Just look at some of the factors that could predispose to type 1 diabetes. We talked about viruses, we talked about the role of diet. And in fact, they say that some predisposing factors could be early exposure in childhood, infancy to cow milk. That's why breastfeeding for at least 6 months, exclusive breastfeeding is very, very key. So early exposure of your fetus to cow milk can predispose to type 1 diabetes later on. We also talk about early exposure to gluten to your child. So at least beneath the age of 1 year, you can try and minimize exposure to both cow milk and gluten. Vitamin D, omega-3 seem to be protective. Other predisposing factors include advanced maternal age, preeclampsia in the mother, things like neonatal jaundice tend to be other predisposing factors. And what's protective are things like low birth weight, short birth length. These are all the things that have been studied in long-term longitudinal studies. But the crucial thing to remember is that we tend to have type 1 diabetes largely being a disease that's not very easy to avoid. There's been things about vaccination, but none of these have been able to be very fruitful in trying to prevent type 1 diabetes. But these are postulates as to what could be some of the factors that cause this. So the main antibodies that cause type 1 diabetes include your islet cell autoantibodies, what we call IAA, islet cell autoantibodies. I talked about glutamic acid decarboxylase, which is what we normally check in the setting of LADA, the case we spoke about. This can be tested, and this is what we use to make a diagnosis of LADA, as well as type 1 diabetes. Then to have what is referred to as the insulin-associated protein, and also you can have the zinc transporter protein. So they're just some of the examples of antibodies that you can see in the setting of type 1 diabetes. If you have, the more antibodies you have, then the higher the risk of you developing type 1 diabetes. Again, the earlier these antibodies occur, and the higher the risk. So if they occur in the age of 5 years, for example, the higher the risk that individual will develop type 1 diabetes. The more the antibodies, like we said, and the more likely that individual will develop type 1 diabetes. So just as a summary, we tend to have the genetically predisposed individual, environmental insults, the autoantigens are eventually produced, and these activate your T helper cells, and these are both T helper 1 and T helper 2, which now cause this production of cytokines, which now lead to the direct destruction of your pancreatic beta cells, either by activating what are referred to as your CD8 cells, your B lymphocytes, as well as your macrophages, and they all finally culminate into this common pathway of causing increased destruction of your beta cells. We know that this is more lifestyle driven. So we tend to have an individual who is obese, sedentary. This will lead to increased insulin resistance. And now because it's much harder for insulin to work, and the beta cells have to produce much more insulin, what you call compensatory beta cell hyperplasia. They must be able to expand in their capacity to produce insulin. So also try and control the blood glucose levels. Because now the peripheral fat, mostly the abdominal visceral fat, makes the insulin much less effective. And therefore you have to produce a significantly larger amount of insulin to control the blood sugar at any particular time. This eventually will lead to impaired glucose tolerance because the beta cells, because they're working harder, tend to get fatigue. Is what leads to manifestation of hyperglycemia. Other mechanisms in type 2 diabetes, we've talked about the beta cell failure due to constant fatigue because of the compensatory hyperplasia. To decrease insulin production in the long run. There are key hormones called incretin, and these are called GLP-1 and GIP. Have a role in what is referred to as a fast, which will lead to free fatty acids, which will also lead to direct destruction of the beta cells. You tend to have increased reabsorption of glucose from the kidneys. Also, the muscles themselves do not take up glucose as they were previously doing. So therefore, there's decreased peripheral uptake in both glucose and the fat tissue. And all these factors tend to culminate in an elevated blood glucose. The liver plays a very, very key role because of the hormones referred to as cortisol and glucagon, which cause increased dumping of glucose from the bloodstream, from the liver into the bloodstream. And also your neurotransmitters tend to be affected. And these are very, very key because these are what actually control your satiety. That is your ability to actually feel full. So people who have diabetes tend to have their satiety center being affected. So they tend to consume more than usual. We call it polyphagia because you can no longer suppress your appetite. And therefore you tend to consume much more if you have type 2 diabetes. So all these factors put together are what actually lead to the rise in blood sugars that are seen in type 2 diabetes, and different drugs that we use in type 2 diabetes tend to target either one of these mechanisms or a host of these mechanisms in combination. So let's now talk about another entity referred to as impaired glucose tolerance. So this is also referred to as pre-diabetes. It's an intermediate state. And what we say, it's an actual warning that if you don't do anything about your diet and your lifestyle, then eventually you'll develop full-blown type 2 diabetes. The lifetime risk of developing type 2 diabetes, if you have pre-diabetes, is around 75%. Within 3 years, your risk of developing type 2 diabetes is around 50%. There's an increased risk of cardiovascular disease in these particular individuals. And therefore, you have to try and adopt a structured exercise program and a structured nutrition program to try and prevent getting into type 2 diabetes. And we see most times, if you adopt this very well, 60% of patients can be reversed back into having a normal blood glucose level. The cutoffs are here, like we've discussed earlier, fasting blood glucose of between 5.6 up to 6.9, and a 2-hour post-meal sugar between 7.8 or 11.0, or an A1C of between 5.7 and 6.4. So very, very key to pick up pre-diabetes. That's why we should screen our patients as much as we can, because it gives you a time period where you can actually reverse things back to normal glycemia through simple exercise and diet, and no medication is required. You don't need to give any metformin or any other particular drugs in this particular setting, and you can actually reverse it to completely normal blood glucose levels. So there's also metabolic syndrome, and there's still a lot of controversy whether this particular condition actually exists. But we know that people who have type 2 diabetes tend to be obese, they tend to have high blood pressure, they tend to have high uric acid levels, they tend to constitute a constellation of findings that we refer to as a metabolic syndrome. There are various diagnostic criteria for this particular condition. And like I said, it varies from society to society, but it does impart an increased risk of heart disease and heart stroke and other macrovascular complications. And it definitely will predispose to eventual development of full-blown type 2 diabetes. So anyone who has metabolic syndrome and may not have over discuss about tests. So like we said, we look at the diagnostic criteria. You can either use random plasma glucose, ideally 2 hours post-meal. Your standard of care is a 2-hour oral glucose tolerance test, or use a 75-gram oral glucose load after your patient has fasted for at least 8 hours. Very, very key. They must fast for at least 8 hours for your OGTT to have correct figures. Or you can use your fasting plasma glucose, and you've seen the cutoffs already. So the key thing, I've talked about your OGTT, is not available in most centers, expensive. We use it very commonly in the setting of pregnancy, where we want to screen our mothers for gestational diabetes, specifically between 24 to 28 weeks. But if available, it's a very, very good test, and it's a gold standard for clinching the diagnosis of type 2 diabetes. But like I said, you can simply use your fasting blood glucose level, or you can use your HbA1c. Now, briefly about the HbA1c, the key things, it's an expensive test. Where I work, it costs around 5,000 shillings, not widely available in a number of centers. Point of care testing for HbA1c has not been very well developed. It's not very accurate up to this particular standpoint. It can be affected in certain scenarios, for example, anemia. We are living in the sickle cell belt in Africa. So again, hemoglobinopathies can affect this. People who have chronic kidney disease, people who are on dialysis can all be affected in terms of having their HbA1c not being accurate or not reflecting an accurate reading. Again, also we've seen that things like smoking, previous carbohydrate intake can also tend to affect your HbA1c level. And again, not a very good test to use in the setting of pregnancy, because we tend to have a mixing of both the fetal and the maternal circulation. So that will tend to introduce a lot of immature red blood cells into the circulation and can give you an erroneously high HbA1c level. So we don't use it at least after the first trimester of pregnancy. So stay clear of using HbA1c in that particular setting for the sake of diagnosis. Better off using a 75-gram oral glucose tolerance test. Other tests that we could use, antibodies when you're looking for type 1 diabetes. We don't check for antibodies for anyone who has type 1 diabetes, but they have a role, like we've said in our case, for the diagnosis of LADA, latent autoimmune diabetes of the adult, and it's GAD65. We do use the C-peptide levels sometimes for people to check whether they have any insulin reserve in the setting of LADA. Urinary ketones can be used in people who are working in resource-poor settings. So if you don't have access to plasma ketones, or a blood gas machine, then you can make a diagnosis of diabetic ketoacidosis using urinary ketones. So again, that can be used in low resource settings and still widely used across the country. And even our Kenyan guidelines have adopted urinary ketones as one of the things that could be used to diagnose diabetic ketoacidosis. The normal way we test is by what is called capillary blood glucose testing. And that's how we normally measure our blood glucose in the clinics, and even for our patients who are testing at home. It can detect both hypoglycemia and hyperglycemia, but remember there are cutoffs above which it cannot read the blood glucose level. So most glucometers will test and can read your blood glucose up to an upper limit of 33, some up to 30. But beyond 33, it will not just show high. It will not be able to give you the exact value. And for hypoglycemia, most can go down up to around 2.5, and below 2.5, it will just show low. It may not give you an exact value. So at least most times, hypoglycemia by definition is any blood sugar below 3.9. So at least between 3.9 up to 2, most meters can actually go down up to 2. You can be able to conclusively make a diagnosis of hypoglycemia. Above 33, then it'll just show you high, just you're dealing with a very high sugar above 33. So normally, as for consent, like any other procedure, you swab the patients with an alcohol swab, or simply they can just wash their hands. Then you can, use the Lancet device and use the tips of the fingers. I normally say, use the tips on the lateral ends, which is less painful for the patient, and let them also rotate their sides. Very crucial to educate them about that, so to avoid pain. When they're pricking themselves, especially for type 1 diabetes, or checking their sugars 4 to 6 times a day, they need to at least rotate the fingertip sides to avoid excessive pain and trauma. Some meters made it calibration, but most meters nowadays, you don't need to calibrate the strips anymore. And you have to also match the strip to the particular meter. So remember that every brand of glucometer has a specific strip, so you cannot move a strip from one brand to another. Very, very key. Ensure the strips are well stored, away from direct sunlight, away from moisture, just to ensure that you have accurate results. Ensure that they're not expired as well, also very, very key. And also keep good records for your blood glucose levels. And indicate the time. Is it before breakfast? Is it 2 hours after your meal? And also it's good to indicate probably if you have a very high sugar, what you may have eaten, to try and pick up trends. If you've got a low sugar and maybe you've exercised, it's good to indicate that I exercised and I got a sugar of 2.4. So as to just help you be able to pick up trends and to help you adjust or titrate your insulin or your oral hypoglycemics, either as a patient or as a clinician. So like we said, just to conclude, we've seen the various subtypes of diabetes, and I said it's much broader, and you see now that there's much, much more apart from just type 1, type 2, and GDM. You must think about things like ladder because they're very, very key. Even if you cannot do a GAD65, think about that individual who's coming in lean with a low BMI, having a high sugar, and coming in DKA, for example. It may not just be type 2 diabetes. So don't label everyone who is 30 and above as type 2 diabetes. Again, also very, very key that our patients keep good records. They check their sugars. We always encourage all our patients to have a glucose meter, because if you're able to check your sugars, then you can pick up trends, and also you can be able to manage your sugars very well and avoid having micro and macrovascular complication. The most, one of our key founders in diabetes said the diabetes who knows the most is the one who lives the longest. So the more empowered, educated your patient is, the patient who checks his sugars regularly, can pick up trends, can communicate effectively with their clinician, are the ones who are actually going to avoid getting most of these complications. And you can live long with diabetes. I have patients who've had diabetes from the age of 30, 20, and I've seen people who are coming to the clinic at the age of 65, at the age of 70. I have one lady with type 1 diabetes who was diagnosed at the age of 8, and I saw her at the age of 68 years of age. So again, it's all about how you take care of yourself. And also, picking up trends, frequent clinic visits, doing all your lab tests accordingly, and ensuring that you actually follow the instructions. Nutrition, exercise play a very, very key role. So all these things are very, very key as you're thinking about trying to provide the best for your patients. Thank you.
Wow. Thank you so much, Dr. Njenga. Thank you so much. We've learned quite a bit from your presentation, and even from where I sit, it's so easy now for me to understand the difference between type 1 and type 2 diabetes, the World Health Organization diagnostic criteria, and so much that we've been able to learn. At this point, I'd just like us to post some questions. So if we have any questions, could we post them on the chat, and Dr. can take time to answer? Any questions? We'll give these about 10 minutes, and please post any questions, or if you have a quick one you want to speak, just raise your hand and the host will allow you to speak. Yes, Willis, you have a question? Habil, can you find out if Willis wants to ask the question without typing it out? Then we can unmute him and allow him to speak. Robert?
They can use the raise hand feature if anyone would like to speak instead.
Right. There's someone called Willis who has said questions. So Willis.
Let me engage him.
Okay, please.
Okay, so probably as people are thinking about their questions, maybe we can run the post quiz. We can use this time. Then we can be able to take the questions, plus I can now go through some of the questions and just highlight the key aspects and the key take-home messages. So please just type in your questions.
Yeah, Dr. Can we just, because there's a question that's already been posted.
Oh,
do you
okay,
want
that's
me to
good.
read it
Okay,
out?
yeah, you can read it. I thought there were no questions.
Yes. Yeah. There's a question from Redemptor Odongo.
Yeah.
In type 2 DM.
Yes.
Is it okay to taper down drugs in case of controlled sugars?
Yeah, so now the thing about diabetes is that it's a very patient-specific approach. So every patient is different, number one. So there are those who in type 2 diabetes will require insulin at the beginning. There are those who use insulin for the rest of their lives. There are those who start off with insulin, then their sugars get well controlled, then they move to oral hypoglycemic drugs. They could use multiple drugs, even up to 4 drugs at some point. Then we see the sugars are well controlled. There's always room to remove from 4 drugs to 3 drugs to 2 drugs. There are even those patients who start off on insulin and actually end up on no drugs at all. So this actually varies from patient to patient. So the key thing is we normally check the blood sugar levels. We see them, are they at target? And the targets for us are fasting sugar of between 5 to 7 millimoles per liter is good control. And a 2-hour post-meal sugar of between 5 to 10 millimoles per liter. So if you're reaching these targets and you're finding your sugars on the lower end, reduce your insulin dose fast. If you find that you can actually come off insulin, you can switch them to oral hypoglycemic drugs. And you, like we said, if you're using multiple drugs and you're still having very good sugars, you can reduce from 3 to 2 to 1 drug. And if your patient is very motivated, they're exercising well, they've lost adequate amounts of weight, we now use a lot of what is referred to as keto or low carb diets, which can also help you reduce your sugars even further. And your people who are actually managing themselves right now. We have diabetes reversal programs which we are running. And we have had almost over 100 patients on our programs, which we ran with a gentleman called Dr. Dan Katambo. And in fact, this data was presented at our national conferences last week. So it's possible, but it varies from patient to patient. Remember, you'll have a diabetic who will require to use insulin for the rest of their lives. And it's good for people to know that, you know, if you've been on insulin for several years and you've not been able to reduce the dose, prepare the patient mentally so they don't always keep moving from doctor to doctor looking to get off insulin. If insulin is your drug of choice for you, which will prevent you from getting an amputation, prevent you from going to dialysis, then just stay on insulin. So like I said, there's no blanket answer I can give you, but it really specifically depends on the patient in front of you, and you must tailor make your management for diabetes for that specific patient and do what is best for them.
Thank you so much.
Yeah.
Mm-hmm. Oh, sorry,
Yeah.
you're continuing?
No, I've just seen a question here. Maybe I can comment on this. Yeah, I mentioned about HbA1c not being the best test to do during pregnancy. That's true. Very, very key. The only time you should use a HbA1c test is in the first trimester of pregnancy, first 12 weeks. So that one can be used because it can indicate for you a lady who is probably, if you get high sugars in the first 12 weeks of pregnancy, remember it's not gestational diabetes. Gestational diabetes can only be defined after 24 weeks of pregnancy, okay? It can occur earlier in certain high-risk women at 16 weeks and above, but any mother having a high sugar in the first 12 weeks of pregnancy, it is not gestational diabetes, it is pre-existing diabetes. That is a mother who was diabetic, type 2 diabetes, she has type 2 diabetes, she didn't know she was having type 2 diabetes, she got pregnant, she goes to the first ANC clinic visit, they find glycosuria in the urine and her sugar is 16. So that's called pre-existing diabetes, okay? So in the first 12 weeks, you can use an A1C, but after that, you cannot use an A1C because like I said, what happens is that you start to have a mixing of the fetal and the maternal circulation. Now what happens is the maternal circulation has a lot of immature red blood cells, which tend to bind, they become very avidly glycated. So they tend to give you a very high HbA1c reading, which is erroneous. So whenever you have immature cells in circulation, then they tend to give you a higher HbA1c. Same concept is if you have an acute blood loss, you've had a road traffic accident, recent surgery, you've given donated blood, for example, and you do an A1C immediately after, you'll have a lot of immature cells in your circulation trying to compensate for the blood you've lost. That will raise your HbA1c. So we normally say that, don't, if you're screening for diabetes and you've had major surgery, you've had a recent blood loss, then wait for 3 months to allow all your cells to fully go through the entire maturation process. After 3 months, a red blood cell takes around 3 months to mature. Then that will be more accurate. So avoid it, please, in the setting of second, third trimester pregnancy for any particular diagnosis. Yeah. Good. Over to you, Ken. You can unmute.
Yes, sorry. There's another question. How does advanced neuropathy manifest?
Yes, so neuropathy, remember, can manifest even very, very early on. So even we've talked about pre-diabetes, and you define exactly what pre-diabetes is. Fasting sugar between 5.6 to 6.9, 2-hour post-meal between 7.8 to 11.0, A1C between 5.7 to 6.4. So even in pre-diabetes, you can have overt neuropathy. Now, in the setting of type 1 and type 2 diabetes, neuropathy is a very, very common symptom. And at least 40% of your patients above the age of 40 will have some form of neuropathy. And the key thing is that it can start off as mild neuropathy. Severe neuropathy now is where it causes debilitating pain in your patient. They're not able to sleep. The common thing we hear from our patients is, I can't even cover my feet with a blanket at night, or even a simple bed sheet. Any simple touch, even a bed sheet, can cause severe pain. Then they also tend to dip their feet in cold water at night to be able to get some relief. You start using drugs like pregabalin to try and bring down the pain, and at times you can use very, very high doses. And at times when it's very, very severe neuropathy, remember that they tend to lose most of the sensation on the feet. So they can also start to develop what I refer to as neuropathic ulcers. So they're able, when they step down, they don't clearly perceive sensation. So they can easily step on a sharp object and not perceive it, and that can lead to diabetic foot. They could have a stone in their shoe and they could wear that the whole day, which could predispose them to a neuropathic ulcer. So severe neuropathy is where, for example, you have complete loss of sensation, and you can have severe pain. The pain can either be in the sense of pins and needles, or it could be a severe burning pain. And we tend to use drugs like pregabalin to try and relieve the pain. But we can also use drugs in combination, for example, tramadol, NSAID sometimes when it's very, very severe. And in fact, sometimes we do involve pain management. That's how severe neuropathy can get. Also try and minimize other factors that contribute to neuropathy. So try and control your blood pressure well. Try and control your lipids, so use a statin where indicated. Stop smoking, stop alcohol use. So again, all these factors cumulatively must be put together to control neuropathy. But neuropathy is a very, very severe condition which actually even leads to depression in patients who have type 2 diabetes and also type 1 diabetes.
Oh, thank you so much. There is a question from Mwelwa. Are there some ways that one can prevent themselves from acquiring diabetes? What are some of the lifestyle choices that one can make?
Yes, so key thing, like we said, we are seeing diabetes at a much earlier age nowadays. And I can tell you, I see around 100 patients a week in my clinic. Out of those 100 patients, I can guarantee you 10% of them are below the age of 40. That's a big figure. And the reason is most of us nowadays are not very active. Ken and Samuel Ogutu, I'm sure were very, very active when they were younger, back in the day in the village. They'd be running around the whole day. But the sad reality is most of our children growing up nowadays are growing up in apartments. Most schools, as you're aware nowadays, hardly have playgrounds. We have schools in the middle of town. We have schools that have they are just, your schools in a previous compound which was owned by someone else. So our kids they're not active anymore. So there's very minimal activity in school. They get home, they have to sit in traffic for around 2 hours. They have to do their homework. On weekends, again, they are watching TV, playing PlayStation. So this sedentary lifestyle is beginning at a much, much earlier age. Then they move into campus, and you could have played a bit of sports in high school. In campus, most of us don't partake in any sports because you are busy trying to study. Again, the dangerous lifestyles begin, smoking, alcohol, which are starting at a much earlier age nowadays. So we are seeing all these are factors put together to make diabetes occur much, much earlier. How do you prevent it? Number one, exercise is very, very key. So we advocate that you must at least strive to do 30 minutes of exercise at least 5 times a week. You must at least do 150 minutes of exercise per week. If you have no issues or any complications, try and also have your your workouts being 50% cardiovascular conditioning and 50% having something called resistance training. That means that jogging alone is not enough. If you can just jog for that, you can jog for 15 minutes, then do some press ups for another 15 minutes. You can run sprints, you can lift a bit of weights. So that helps to build up muscle. And you've seen in our previous diagrams, the muscle plays a very key role in mopping up glucose on your bloodstream. So if you're young, you don't have any major issues, don't just jog. Try and have 50% of your workouts being more intensive, short bursts of very vigorous exercises, which can either be star jumps, you can run sprints, you can do aerobics, you can do push-ups, you can do sit-ups, you can even improvise weights in the comfort of your home. Those are very, very effective ways of building muscle, and they are very effective combined with your brisk walking, with your running, then that's very, very effective. Other effective exercises that people don't do much but are very, very effective in actually controlling weight and minimizing diabetes. There are two very key exercises, swimming and cycling. And the beauty about those exercises is that they actually combine both the cardiovascular component and also they combine the resistance component. And in fact, if you look at your Guinness Book of Records and you look at the world's fittest individuals, they have all been either cyclists or swimmers. So the world's lowest heart rate is at 28 beats per minute, and that's by a deep sea diver. And before that, that was held by a former Tour de France winner, Miguel Indurain. So cycling and swimming, if you're able to do those, are the most effective exercises because they combine two aspects of cardiovascular conditioning as well as resistance training. The other key thing is your diet. What you eat is very, very key. So as much as possible, minimize your carbohydrate intake. So if you can cut down your carbs and do what is called low carb diets. So what you simply do is minimize your carbohydrates, and you can even have more of protein. We've demonized meat and eggs so much, but trust me, you'd rather have more eggs and meat than have your bread, your oatmeal, your cornflakes, your chapati, and your rice. So remember that all these carbs have sugar. If you consume half a plate of rice, you're consuming the equivalent of 14 teaspoons of sugar. So remember that. If you have half a plate of ugali, you're also consuming the equivalent of 10 spoons of sugar. So there's no difference between you taking 10 teaspoons of sugar and eating half a plate of ugali. Those two are equivalent. So the more carbs you withdraw and add that to plant proteins, your lean meats, white meats, especially chicken, fish, then those are very, very effective. So don't demonize the eggs. The eggs are very good. If you can remove the toast and bread from your breakfast and replace that with egg, that is much better for you to control diabetes and your weight in the long run. Oatmeal is not good, I can tell you. So remember, carbs are carbs, whether they're brown, white, the lower carbs you consume, the better. So if you're trying to avoid diabetes, trying to lose your weight, try and minimize as much carb as you can. Brown carbs, we advocate for them because they are more complex. They take a longer period of time to break down. But all in all, you want to consume lower amounts of carb is your aim. If your aim is to reverse diabetes, to come from pre-diabetes to having normal blood sugars, or if your aim actually is to lose weight and to lose fat around your midsection. Yeah. Wheat is still carbs. So remember that. So carbohydrates come in various forms. Wheat is your Wimby, it's still carbs, end of the day. So try and minimize it. The key message is the lower carbs you consume, the lower likelihood of you adding weight and the lower the likelihood of you developing diabetes. So you can have your carbs, but minimize them, minimize them, minimize them. Let half your plate be vegetables, which will help you get full. Then consume a bit more proteins, preferably white meats, and then you can have a lower proportion of carbs. That's the key message I want to put across.
All right. I'm still stuck where you said we reduce the amount of chapati we eat. That
yes.
Well, have to live with that.
Yeah. Yes, it's a reality.
There's a question, Dr. about what's your opinion? I think there are two questions. What's your opinion on a patient being on Nuglac alone and starting metformin at 1 gram twice a day instead of 500 or 850?
Okay, good question. So normally for metformin, we advocate start low, begin at 500 milligrams for all your patients, and you can begin at once a day, twice a day. Now again, starting drugs again depends on what your blood sugar level is. So if someone's sugar is 26, for example, starting metformin at 500 milligrams once a day is not going to do anything. So if the sugar is extremely high, remember what you need is insulin, okay? If your A1C is between 6.5 to 7, you can use a single drug regimen. And metformin is a good choice to start with. Start at 500 milligrams once daily. Check for any GI symptoms because things like nausea, bloating, diarrhea can occur. If there are no symptoms, you can up titrate to 500 milligrams twice a day. And eventually, aim to have them on 1 gram twice daily. Now, no-gluc, I know, is a drug that is very, very commonly used, but it's a drug that we really are trying to get rid of in this particular country. The new guidelines actually have we've officially removed no-gluc from our guidelines. If you look at the new diabetes guidelines, we've just completed our medical formulary for drugs, which are going to be, since I think RUFA is here, the new formulary actually doesn't have glibenclamide anymore. We've removed it because now we have cheaper forms of better drugs like gliclazide. We have a lot of generics in the market now, which are much cheaper. That's a much safer drug to use because the issue about no-gluc is the risk of hypoglycemia, especially in your elderly patients, especially in your patients who have chronic kidney disease. You know, you may be working in a rural setting. You don't know what someone's creatinine clearance is. They could be having CKD stage 2. You start the drug and they die at home, okay? It's a very dangerous drug, in my opinion, and we're trying as much as possible to phase it out. So it's not a drug I'd use in single use, but I'd advocate for the use of gliclazide. And I think this will begin to change as the new drugs are being rolled out by KEMSA and meds. We've definitely removed no-gluc from the formulary, and at least in the coming months or years, at least, hopefully by end of the year, this drug will at least be out of most of the government facilities. Yeah. Good. Maybe in the same light, there's someone who's asking, can someone who's been on insulin be converted to oral hypoglycemics without any complication? Yes, it's possible. Like I said, again, it's patient specific. If you start insulin on a patient and their sugars progressively drop with the targets that you're looking at, you find that they're now becoming low. What you do is to reduce the dose of insulin gradually with time. And you find that once someone is on very low dose of insulin, for example, you're using only 6 units a day or 4 units a day, you can safely transition them to oral hypoglycemic drugs. Another key point is, remember, if you're using insulin, that doesn't mean that you don't use your oral hypoglycemic drugs. The key management is you use insulin in combination with your oral hypoglycemic drugs. And what you want to use specifically is metformin together with insulin, or you can combine metformin and any DPP-4 inhibitor together with insulin, because those two drugs don't cause hypoglycemia. Never combine insulin with any SU, like glibenclamide, gliclazide, and never combine metformin with any drug like pioglitazone, because again, that will cause fluid retention. So remember that when you're on insulin, that doesn't mean you don't use your oral drugs. And it's possible, like I said, if you're on very low dose of insulin, recurrent hypoglycemic events, you can safely switch your patient over to oral hypoglycemic drugs. Let them monitor their blood sugar levels. If they're on multiple drugs, 3 drugs, 4 drugs, you can reduce from 3 to 4 to 2 to 1. So it's possible. But like I said, walk the journey with your patient because it's patient specific. There's no solution that fits everyone else. Those who have to remain on insulin must remain on insulin, and please insist that they must remain on insulin. There's always a tendency that I want my mom to come off insulin. People travel all the way from Bungoma, Northeastern, all the way to my office, pay the consultation. We've come here because we want to come off insulin. And I tell them you can't come off insulin. So please, let's know that insulin, let's not demonize insulin. Insulin plays a very, very crucial role. It is not a death sentence to be on insulin. What you want to do is to ensure that you have good control to avoid macrovascular and microvascular complications. Yeah. Yes, and the presentation, I've shared it with Sam Ogutu and team, so please feel free to disseminate as widely as you can. So anyone can get the presentation. That's free of charge, and I'm happy to give it to anyone.
Just to add to that, as a matter of routine, the program shares the presentation and even the video. So you will be able to get these in the next day or 2. So don't worry about that. Now, we have just about 10 more minutes. So I would suggest that we have the quiz and then any further discussions, if we have time, then we can have some additional discussions after that. So Daktari, maybe you could just stop sharing your screen.
Okay, no problem. Let me just do that. 1 second. Good.
Thank you. Over to you, Habil.
Yeah, the quiz is on now, so let's all attempt it. Once again, it's just testing our learning. So I would encourage everyone to attempt it. Then Daktari will discuss the quiz after we've posted. Thank you.
Could we please have attempting the quiz, please?
Yeah.
Don't worry about it's a self-test, so don't worry about getting an answer right or wrong. Thank you. We can see some people have started. More, please. Yeah, 64 now.
We're waiting for a few more responses, please. I think we're good to go. Thank you very much for all those who have attempted the quiz. I'd like to request Dr. Njenga then to discuss this quiz, and then we can end. Dr. Njenga, please.
Good, yeah. So we can go through?
Yes, please.
Okay, good. Yeah, so I can see 79% of people got the answer correct. So the primary etiology, like we said in type 1 diabetes, it's not insulin resistance. Remember what we talked about autoimmune diabetes, either LADA or type 1, that they are always lean, BMI less than 25. It's not incretins. Remember we talked about the ominous octet. Incretins are your GLP-1 and GIP. Those are commonly seen in the setting of type 2 diabetes. The primary mechanism, like we said, you are genetically predisposed individual, environmental factors, which include viral infections, which trigger the production of autoantibodies like islet cell autoantibody 2, zinc transporter protein, GAD65, which all lead to your pancreatic beta cell destruction. Once you damage 80% of your pancreatic beta cells, you begin to manifest type 1 diabetes. Decreased peripheral uptake is seen in the setting of type 2 diabetes. Your transmitter dysfunction is what causes your loss of satiety centers, your dysfunctioning of your satiety centers, so you don't feel full. That's again in type 2 diabetes. So most of you got it right. I'm happy, 80%. Question 2. Which of the following is true regarding the diagnostic criteria for diabetes? So I'm still a bit sad that we only 66% got this right. So remember, we said that if you have an A1C of 6.5 equal to, remember it's equal to, that's already type 2 diabetes. So it's not about above 6.5, it is equal to. Same with if you are fasting equal to 7.0, that's already diabetes. A 2-hour post-meal sugar equal to 11.1 is already diabetes. Okay, that was a catch there. Fasting sugar should be taken at a minimum fasting period. It's supposed to be 8 hours and above. Remember that. 75 gram oral glucose tolerance test is not only used in pregnancy, it can be used to confirm diabetes. We commonly use it in those gray areas. Someone has pre-diabetes, borderline sugars. It can be used as a gold standard to diagnose type 2 diabetes. So it's used outside pregnancy. So remember that. And the diagnostic criteria is the same for both pregnant and non-pregnant people? No. GDM has a very, very different diagnostic criteria. So just to give it to you, the criteria for GDM is much, much tighter. So it's a fasting sugar of less than 5.1. So any sugar of 5.1 and so any sugar of, above, any sugar equal to 5.1 and above is equal to GDM. So much, much tighter. Remember, our fasting sugar for type 2 diabetes is 7.0. For GDM at 24-28 weeks, it is equal to or more than 5.1. Then the 1 hour value is equal to or more than 10.5. And the 2 hour value is equal to or more than 8.5 when you do that 75 gram oral glucose tolerance test. So the criteria is different for pregnancy and non-pregnant state. So yeah, I would have at least wanted to see 90% of people getting that right. And this I see is people, when I do surveys, whenever I go to train outside, even in Nairobi and outside Nairobi, people struggle with diagnostic criteria. So what I suggest is please go back and cram those slides again. Just keep telling yourself daily, so that you don't miss. If you cannot diagnose diabetes, then I think we are really, really doing a disservice to our patients in the primary healthcare facilities. So please, just what you do is you look at that slide tomorrow morning, Sunday morning, Monday morning, Tuesday morning, Wednesday morning until you can sing it. Once you can sing it, then you'll be very, very happy. So please, 66% is still not a good cutoff. We need to have everyone there at 90% at least for diagnosis. And I think that is the primary aim of this teaching series, that we get the basics right at least. So the mechanisms for type 2 diabetes are here, except which ones? So the one that again is wrong is primary beta cell failure due to autoimmune. Remember, autoimmune is always type 1 diabetes. So again, only 52% of people got that right. So remember, we don't have any autoimmune etiology in type 2 diabetes. It's purely insulin resistance, and we have other mechanisms that we talked about. So remember, there's no autoantibody in the setting of type 2 diabetes. Which of the following is true about a HbA1c test? Widely available and affordable, we said it's expensive and not widely available. Point of care machines are not very accurate, and we discussed the use of point of care machines for HbA1c. Accurately depicts glycemic trends. Actually, it does not. You can have someone with an A1C of 7%, yet they can have spikes in between of 18s and 7, which could be missed. So remember, it's just an estimation of your average glucose over 3 months. So we are now shifting to a modern era. We're talking about CGM, continuous glucose monitoring, but we're still far from that in sub-Saharan Africa. But remember, A1C is a rough estimate of how well you're controlling your sugar. So then accurately 100% tell you that everything is okay. You still could be having hypos, you still could be having hypers. So it can be used in late pregnancy. We said don't use A1C in the setting of 2nd and 3rd trimester pregnancies. And the correct answer was E. It can be affected by factors such as anemia and hemoglobinopathies. And like we said, chronic kidney disease are other factors, recent blood loss, are other things that can also lead to this, and pregnancy as well, of course. So the correct answer there was E. But at least the most of you got it. At least I can see 48% of you got it. So again, key questions that highlight on the key points of our talk. And I think most of you have understood them very well. So again, get the slides, please go over them again. Know the diagnostic criteria, know how to diagnose diabetes, know the basics of the pathophysiology, and how to see how your patients present in clinical practice. Key take-home message: people with type 2 diabetes most times are asymptomatic, and that's why it's a silent killer. You can walk around with a sugar of 20 for even 5 years without realizing it. So remember that screening is what you want to do as much as you can. So thank you so much, Ken and Samuel, for organizing this wonderful session. And I look forward to being back on your platform. Excellent job, and excellent job for everyone coming together. We form an umbrella body as Kenya Diabetes Study Group called NCD Alliance. And this would be being part of the task working group in diabetes. I'd say I'm truly proud to see such initiatives. And I think we should have you on our task working group. I think you are actually touching a lot of patients' lives, and I think you're a very key component. So I will definitely invite you to most of our stakeholder meetings with the ministry and keep doing a good job in educating the masses and also our patients at primary healthcare level. Thank you.
Well, thank you very, very much, Dr. Jenga.
Yeah.
Truly appreciate.
Maybe one more point. Yeah, since I'm here, we are going to have our annual diabetes conference in June this year in Mombasa. So I'll probably reach out to Samuel and give him all the details of how you can get in touch with us. For those who are interested, it will be Mombasa, and that will be a 3-day conference. So we'll be able to highlight all these things in much greater detail. Thank you so much. Yeah.
Thank you. Thank you very much, Dr. Jenga. We truly appreciate your lecture and all those very kind, words. Now, let me just share. I think we've come to the end. Let me just share my screen. Right. Now, our next event will be on Thursday, April the 28th, 2022. And we will be, the topic will now be going into look at the acute complications of diabetes. And the presenter, who is a close colleague of Dr. Jenga's, is Dr. Rosemary Wanjiru. It will be at 6 p.m. From 6 to 7:30, just like we had today. And now, we would also like to, you to share with us any topics that you'd like us to address. But as my colleague Ken had mentioned earlier, we are right now, on a series on diabetes. We really want everybody, each health worker, to be able to know the very basics, of diabetes, so that, as Dr. has mentioned, we can be able to do, greater service to our patients. So we would appreciate any feedback on topics that you want us to address. On top of, in addition to diabetes, we will be having a series on hypertension, but then we could also, have others as you may suggest. And so, ladies and gentlemen, well, thank you very much for your time. I think I'd like us to just all unmute and give Dr. Jenga, a big clap.
Well done. Thank you so much, Dr. Jenga.
Thank you.
Nice having you here. We hope to see you again soon.
Thank you, Dr. Jenga.
Thank you, Dr. Jenga.
Thank you very much, everybody.
Thank you, and glad of being on board. Thank you so much. Have a good evening.
Have a good evening, everybody.
Thank you, Ken and Samuel.
Thank you.
Bye.
Thank you. Thank you. You're very welcome. Hope to see you again next month and the month after that.
And always.
And always. Thank you, Pamela.
Thank you, Pamela.